In the intricate world of cardiology, the electrocardiogram, or ECG, is a vital tool for diagnosing acute coronary syndromes, a spectrum of conditions that includes unstable angina, non-ST segment elevation, myocardial infarction, and ST segment elevation myocardial infarction. These syndromes are the result of reduced blood flow to the heart muscle, often due to a ruptured atherosclerotic plaque in a coronary artery. When a patient presents with ST segment elevation myocardial infarction, or STEMI, the ECG reveals distinct features. The most critical is the ST segment elevation in leads corresponding to the heart area affected by the occluded artery. Sometimes, reciprocal changes, such as ST segment depression in opposite leads, are also observed. Clinically, STEMI is an emergency, signaling complete coronary artery occlusion that demands urgent reperfusion therapy like angioplasty or thrombolytic therapy. In contrast, non-ST segment elevation myocardial infarction and unstable angina often manifest as ST segment depression or T-wave inversion on the ECG. These changes can be dynamic, evolving over time. STEMI indicates partial artery occlusion leading to myocardial injury without complete infarction, while unstable angina reflects reversible ischemia, both necessitating urgent medical evaluation due to their high risk of progression. Beyond these specific conditions, other ECG findings are common in acute coronary syndromes. Pathological Q waves, for instance, emerge hours to days post-infarction, signifying irreversible myocardial damage. They are considered pathological if they are over 40 milliseconds wide, more than 2 millimeters deep, or if they constitute over 25% of the depth of the QRS complex, especially in leads V1-3. Bundle branch blocks, whether pre-existing or new onset, can complicate ECG interpretation, as can left anterior or posterior hemiblocks. PR segment depression may signal atrial injury, particularly with inferoposterior infarctions. Additionally, ST segment depression in multiple leads could indicate multivessel disease, and ST segment elevation with Wellens's sign points to critical stenosis of the left anterior descending artery. The ECG is an indispensable component in the diagnosis and management of acute coronary syndromes. The specific ECG patterns observed not only help classify the type of ACS, but also guide the necessary interventions. Coupled with clinical assessment and laboratory markers such as cardiac troponins, the prompt recognition of ECG changes is crucial for effective treatment. To minimize myocardial damage and improve outcomes, individuals with suspected ACS should seek emergency medical attention for prompt evaluation and intervention.